Moshi Moshi. Let's talk about the future. I'm Kristy Bird MaKieve, CEO and founder of Evergood Podcast. And we are going to be focusing on healthcare education innovation, which are three words most people don't really put together into a sentence. And I also think we'll be focusing on hope for communities. When you have the ability to address access to care, it's also economic development. And we are so excited today to talk to Dr. Natalie Nevins, who I consider a friend and somebody who I've had amazing conversations with for several years now. And so excited to have here with us Dr. Nevins to talk about all the things. We're not going to recreate our conversations, but we're going to focus on medical education in particular. I want to introduce you, and it's a lot. So, this is your signature from your email. You are a DO, MSHPE, MSS, FACOFP, FS, and a colonel in the U.S. Army. You are a professor of family medicine and neuromusculoskeletal medicine. Can't even say the word. Associate Dean for Graduate Medical Education and Program Development, where we really connected. You're with Touro University, California, College of Osteopathic Medicine, and you're a senior fellow for the Center for Disaster Medicine and a clinical professor of public health, New York Medical Center. So how about you introduce yourself?
Sure. I have a lot of hats, but that's okay. I think that at this point, I say we live once, so you need to live it as fully as you possibly can. Obviously, as the Associate Dean for Graduate Medical Education at Touro University, California, my focus is on building graduate medical education, supporting GME sites within the state of California and other places as well, and educating other medical leaders on how do we develop graduate medical education. And for those people who don't know, that means building residency programs for medical students to train specifically within the communities where we hope that they're going to set up their practices. And that means especially reaching into the rural communities that do not have enough physicians, that may have district hospitals, small hospitals, but helping them to work together to be able to have medical students in residence, so we create a pathway of people building roots in communities so they stay there. For my position at New York Medical College, I'm in the Center for Disaster Medicine specifically, and I head up the Immersive and Visionary Medical Technology section, really looking at how do we integrate AI, machine learning, virtual reality, extended reality into medical education and training, and really also into how do we do it for medical care, which is some of the things we're doing with the military, which I'll talk about in a second. I'm also a professor, adjunct professor of family medicine at the Uniformed Services University of Health Sciences, which is the all-branch military medical school. And I just finished up my command in the Army Reserve with 2nd Medical Training Brigade, and I'm now heading off to be the command flight surgeon for the Army Reserve Aviation Command, going back to my roots as a flight surgeon. So very excited to be going back to support them. But all of it sounds like it may be different things, but they really all are very similar because medical education, whether that's within the military or within a civilian entity, the goals are really all the same, is to make exceptional, empathic, caring, talented physicians and other healthcare providers, right? Whether those are physician assistants, nurse practitioners, nurses, medics, dentists, whatever it happens to be, that we are interprofessional when we talk about medicine. Medicine is a team sport. It is not done individually. Physicians are not kings or queens of the hill. They are part of an interdisciplinary team that takes care of people, holistically cares for people. And that's really where the osteopathic portion of my world comes from, which is really looking at how each individual is an individual. They're not just a conglomeration of diseases or race. They're a whole person. And we have to look at them individually as a whole person, all their package, and how do we take care of them effectively. So I think that's most everything I do.
What inspired you to become a physician?
I get asked that question a lot. Um, I think it was probably inevitable. I did my first aid course when I was 8 years old. Um, a full CPR first aid course. You can imagine I'm pretty old, so I'll be 60 in December. And in the 70s, it wasn't very common for an 8 year old to pick up the phone and call to register herself for a first aid course. And they're like, "How old are you?" And I'm like, "I'm 8." And they're like, "Well, you have to have a parent." I'm like, "Okay." And so I dragged my mother along to do it. And I think I had been the caretaker of my family since I can remember. When I was 4 years old, my nickname was the 40-year-old midget. So that will probably put in perspective the fact that I think I've been the mom or the caretaker since then. And then as I went through high school as a student athletic trainer and into college, um, I really focused on really again holistic care. Did an interdisciplinary studies major, initially not thinking I was going to be a doctor, was going to be a geneticist with a minor in Japanese, and transitioned into doing medical anthropology, exercise and sports science, and molecular and cellular biology, because I realized it might have been the last opportunity I'd have to have a depth and breadth to my education. And I really felt that if I was going to go into medicine, once I decided that that was my goal, is I needed to understand how people looked at health and wellness within a culture. And that's really why I studied medical anthropology. Getting to understand and studying languages to go along with that, because you learn a lot about a culture from their language as well. Looking at their food, looking at their religion, looking at their environment. All of those things matter if we want to be able to have empathy and to step into the shoes of our patients to have a better understanding. We will never understand everything, but we need to learn how to be able to ask the right questions, which is, I don't tell you how to care for yourself. I ask you, what do you need? What matters to you? How can I partner with you for your health care? And that's really how we focus on teaching our medical students, which is recognizing that we are a team, not with just our other medical professionals, but with the patient and their family, because they don't exist in a vacuum. So I think it was recognizing. I ran a nonprofit for humanitarian aid for almost 12 years, caring for people in very marginalized communities across Southern California, India, the Himalayas, Mexico. And what I say is that if any part of our world is suffering, we are all suffering. And it is true of our communities. You can't pretend that if you have a rural community or an urban community, that if there's an area within that community that is not thriving, that is not healthy, the whole community is not healthy. And unfortunately, in most cases, people turn a blind eye because it isn't easy to deal with, whether that is opioid addiction, homelessness, mental health, all of those components. It's easy to just say it doesn't exist, but it does. And it is our responsibility as a community to have a healthy community. We all have to take care of each other. It is a village, right? It takes a village to make it all happen. And you, as you know, I also say that we get much farther through collaboration than we do with competition. And we realize, there is competition and greed that is out there, but there's really no room for that in healthcare. Because if our primary goal is the patient and their family, it can't be about competition. It has to be about collaboration. And that's the only way we uplift people. So rather than stepping on them to get to a higher place, our job is to uplift our communities for equity and to support them to be who they are. We're not asking them to be a different culture, a different community, a different language. Instead, we support them and meet them where they are. So hopefully that answers the question.
You touched on something that I just learned yesterday, which is that 95.2% of California is rural, is a rural census block.
Yeah.
And I don't think a lot of people, I think that's what in my last position and how we met, I don't think we had that in our sort of, I mean, we kind of know it from the work that we've done, but California is actually quite rural. And I might even say that's a large landmass, maybe one of the largest rural census tracts in the United States. And it's
Well, massive.
California.
Yeah, California's a massive state. People don't realize how large we are. And that also
Yeah,
goes for our Native American populations. If you look at, there's over, like 570 or so federally recognized
right.
tribes across the United States, but we've got over 100 just in California. We have the largest Native American populations as far as different numbers of tribal nations within the state of California. There's so much of us that are rural, underserved, marginalized populations that it's really easy for the urban areas, the San Diego, LA, San Francisco, that's what people think about, but that is not the majority of our state.
Right. Right. Um, and I actually am going to jump ahead to this question because you started it. Uh, let's talk about tribal medical education. I think that's where you and I really had an amazing mind meld a few years ago, and uh, it is part of, I think, some national efforts, but like ultimately, let's talk about why California might benefit from having its own tribal medical school or its innovation in the space. You've actually been on some really incredible task forces that I wish I had the time to be involved in myself. But let's hear it from you on all the things that have been happening in this space.
Sure. So there's a lot of different task forces that have come together. One is iHeart, that's the Indigenous Health
Mhm.
Education Resource Task Force. I'm on that. I'm not Native myself, but I have grown up with Native communities growing up in Arizona. And part of my time working with the Native American population in Arizona with my degree in medical anthropology as well. The reality is, this is a community I feel very connected to. When I was still running my own private practice, I had an Apache medicine woman who worked in my office with me, and she still runs the practice once I left. The fact is, this is a community that has been bluntly persecuted, even worse, I think, in California than many other areas. And much of it is unknown. The history is not well known by those who live in California, and it needs to be, right? There's certain things that we need to shine a big bright light on. So I'm part of the iHeart team specifically for California, Alaska. I'm also part of the American and Indian Medical Education Strategic Alliance. It's called AIMS. Their focus is on maximizing collaboration. Remember that crazy word that I talked about before? Really to try to bring meaningful change to tribal medical facilities through expanding graduate medical education. And it's really through those partnerships to try to help reduce physician shortages and support the communities that need to happen. I'm an associate member of the Association of American Indian Physicians. Like I said, I'm not Native myself, but I feel that this is a population that deserves our support in every possible way. I think what most people, again, don't understand is, like I said, for California, we have over, I think it's 109 federally recognized Native American tribes. But there's also another like 65 groups that also identify that have not been federally recognized. But yet, if you look at the number of Native American and Native Alaskan physicians in California, it is 0.1%
Yeah.
of, which is amazing when you look at, we have over, I think, 130,000 physicians in the state of California. And then if you look at the national census, it is about 0.3%, maybe close to 2,500 across the entire nation. That is incredibly small when you think
Yeah.
about it. And when we look at, again, cultural competency, understanding a community's needs and their history, their reason for being untrusting, right, has been
Mhm.
earned. To not trust a government entity to take care of their community when they have been consistently persecuted, marginalized, had their land taken away from them. So if we look at the fact that this is a community that knows themselves the best, and that doesn't mean that non-Native physicians can't care for Native patients, but you have to be educated to do so. You need to understand that the other problem we have is that consistently people think that if you've seen one Native American tribe, you've seen all Native American tribes. You haven't. The fact is, they're all different. And trying to lump them all together is the other problem we have. You have to understand that each one of them has their own culture, their language, their philosophy, that there may be similarities, but they're not all the same. And that's like trying to suggest that, every different flavor of someone who is Christian is all the same, or Jewish or Muslim. They're not. There's different aspects to them and their community that make a difference. And so where they lived meant what kind of food they used from the land. It's not the same, right? So those that had salmon coming through their streams are different from those who didn't have salmon coming through their streams. And they have different ceremony. So the ethnocentricity that we see of those who think that they understand Native Americans is mind-boggling. We've seen it with our Latina and Latino population. We've seen it with our African American population, these lumping of people into groups, Asian Pacific, that they're just lumped and somehow that magically makes it all work, and it doesn't. And when we look at medical education, it's not just a challenge of creating more Native American physicians or Native American nurse practitioners or physician assistants or anything within the health professions. It's that when you come from a very rural area, and when you think about that disproportionately, our Native American population live more in rural areas than any other population. Most people have never been to a reservation. They have no idea that in many places there's not paved roads, or there may not be power or running water. And they make really horrible assumptions that because that there's casinos run by tribes that they're rich, which is ridiculous, or that Native Alaskans, because there's oil, they're rich. Once you distribute the funds that come from those places, it's a very small amount of money that get to each tribal member, right? So these myths are horrible, and they only perpetuate the disinformation of how we care for this community. So much like we've tried to uplift every marginalized population to see themselves being able to be a healthcare provider, that takes mentoring. And for those who've never had a person in their family graduate high school or college or go on to a graduate degree, how do you see yourself in a world that you've never visioned, right?
Yeah. Yeah.
And I think from the standpoint of what I do and what we're trying to do is create pathway programs, K through 12, reaching back early and showing them and mentoring and hopefully bringing those who are Native physicians to also be part of that mentoring. It's not just those who are non-Native, but those who are Native, showing them that it can be done, having respect for cultural diversity. I think one of the examples that probably hit me the hardest was one of my Native American colleagues who said that when she went to medical school, we have anatomy lab, right? We use human cadavers that are donated, and those bodies are respected and treated with respect. But in her Native American culture, cutting a deceased human body is not something that's accepted. That would be taboo. But she knew to be a physician, she had to do that. And so her comment was that she said every day she stepped out of the anatomy lab, she wondered if God was going to strike her dead. That's nothing that somebody should have to think about to become a doctor or any other health profession. And in this day and age where we have the capability with virtual reality, augmented reality, we can teach anatomy without someone having to desecrate their beliefs to do that.
Yeah, there's some amazing virtual
Oh my gosh, anatomage tables and all sorts of things that exist. But that's a perfect example of a cultural insensitivity that perhaps a professor would have never known. But it was also something that she as a student didn't feel safe
Right.
telling, right? It wasn't a safe environment to admit something. I think we have a lot more Native students who are partially Native who may never disclose they're Native to their school because they don't want to be marginalized. So we have a long way to go. But from my standpoint, it begins with pathway programs where we reach back, we mentor, we support, we use grants, we educate, and we have the medical student reaching back, we have the physician reaching back, really helping them to see that they can get there. And there are some great programs that are out there. I mean, obviously in California, we have tribal prime programs through the UC system, but it's a very small number of students that are going to qualify for that. And in many cases, they wind up going through a master's in biomedical sciences first to get their GPA up or their MCAT scores up to go to medical school. If we mentored earlier, they would never need that, right? We don't need to make them have potentially more debt or more time before they can become the physician or whatever flavor of health profession they want to be. We have to begin sooner to support these communities.
And I understand that it's also the need to have more Native American faculty teaching the medical students,
Yes.
and there's only so many that in
Well,
the
that's
country.
the
So
hard part, right? Is that
yeah.
we have some great successes. Like, so Oklahoma has they did a joint venture. So they have a tribally sponsored Cherokee Nation, tribally sponsored medical school, which is amazing. We know that there's an indigenous medical school that's in the process of being put together. I know that those coming out of Johns Hopkins and others have really come together with AAIP to try to make that happen. But we need to do more. And I think that California is a really good place to look at tribal affiliated medical school, but also interprofessional.
Right,
And
right.
and I will say that, and I'll be biased for my moment. I'll put on my Toro hat, right? Which is, as osteopathic physicians, we embrace holistic care. It literally is our mission, right? Which is that we're looking at each individual as the individual they are, and that we look for health, not just disease, and that we understand that human beings are integrated at all levels, right? Structure and function are integrated at all levels, but so are communities, right? And that's the beauty, is that you apply that osteopathic principle to the whole community. We are integrated at all levels. And so therefore, if we want the structure to function properly, we want the community to function properly, it has to be integrated. We have to collaborate to make that happen. But it's absolutely vital that those tribal entities, those tribal leaders, have the key voice in how that is developed. And it's not something
Right.
external. They're not being told what they need. We ask them what they need. And so I'll give you my wish list for the moment,
Okay, I'm writing
right?
it
My
down.
wish list,
Yep.
which is to take that in the North State and bring the public health departments, the universities, the hospitals, the clinics, the tribal nations, Indian Health Service, the California government, bring everybody together at the table, much like you did when we're looking at healthy rural California and trying to really bring medical care to the North State. That now we need to go bigger and bring all of the stakeholders together
Mhm.
and say, how do we do this? How do we stop this competition thing and figure out where is the best place for the North State to support some type of, whether that is affiliated with a Toro University or it's its own individual medical school, interprofessional school. How do we all collaborate together to make this a reality that eventually we'll have scholarships to support the education? Because as we know, graduate medical education is under fire with the removal of the Grad Plus loans, significantly diminishing the capacity for those to take loans out to go to medical school or PA school or anything else. Why is that a problem? Because those who are marginalized and come from really underserved populations will have a harder time being able to get loans. They're more likely to get predatory loans. And I can
Mhm.
say that personally, and since I lived it when I started medical school a really long time ago, that happened to be the one year where they didn't sign the bill to do federal loans. So the year I started medical school, I had to take out private loans at a ridiculously high interest rate for medical school for that 1 year. Um, that 1 year took me over 10 years to pay off. I had to finally, refinance it, get it under something else for a lower number. That's ridiculous. And that's a long time ago when it wasn't as expensive as it is right now, right?
Yeah.
So we're looking at how much debt they have. When you're somebody who comes from a population, a marginalized population where you're like, how would I ever pay that back? Even though we know they can as a physician or a nurse practitioner or as a physician assistant, it's pretty hard to imagine if you've never made that kind of money, how you would have that kind of debt. So
For
I know,
that, right? If the first gen thing is a real consideration where the concept of even, a bachelor's degree is a part of the medical education journey,
yeah,
that they're not even um, able to understand that step of the process and how
how do you get
much
to the next
money
step?
is needed for that
Yeah,
step, one
exactly. And
step.
so one of the things Toro is doing right now is we're trying to work with known lenders,
Mhm.
specifically to make sure that we know who is not a
Oh,
predatory
nice.
lender,
Yeah. Sort
and
of
to try to
approving them.
secure, yes, to try to get secure low interest uh, rates, deferred rates as much as possible.
Mhm.
I think that nationwide, they're all seeing that this is something where they can support in place of those Grad Plus loans, but it is a significant disservice in every way, shape, and form for us to be losing the Grad Plus loans to support when we already have a physician and healthcare provider, especially primary healthcare provider shortage, to literally cut the lugs out from underneath those who want to go to school.
Well, that is one of those data points that I feel like I need to be saying in every single one of these podcasts that we record, which is the looming shortage of physicians in just what, 5, 10 years?
Well,
What a
it's already now, right?
Yeah.
We already know that we've got a large population getting ready to age out.
Mhm.
We also have a large population of healthcare providers who've just burnt out. COVID uh,
Right.
pushed a lot of people to the edge. They chose to retire early. If you look at the kind of the census for California, as just as an example, we have a large proportion of physicians or healthcare providers that are over 50. People are trying to decide how to retire early, move someplace else altogether. Um, and it is really a challenge that we also have to develop more graduate medical education because there are more medical schools that were developed, but they didn't necessarily actually
Yeah.
develop residency programs to support the number of students that they were creating.
Yeah. So
And
let's
so,
let's
yeah,
talk about
sure.
that historical bit for a minute, which is that
Yeah.
about 10, 15 years ago, I think a lot of the medical schools said, that's it, we're going to increase enrollment. But the pinch points are the year 3 clinical
Yep.
rotations, because you kind of max out your community around the medical school and that main hospital, and then sort of getting innovative in those spaces of where to send the medical students. But
Hmm.
it's also the graduate medical education
Hmm.
programs also have to expand.
Absolutely.
And so, I never really thought of it as the total number of DME programs because then there's, every subspecialty in the, primary care, family medicine,
Hmm.
I am. So where it really becomes strategic planning that needs to happen now to make sure that those spaces are available to meet the growing needs. And we haven't had a problem with medical school enrollments overall in terms of so we were just talking about Morehouse because of
Hmm.
the work that I'm doing with the Santa Cruz folks. But they made a commitment to expand enrollment from 100 to 200 medical students. And then they had to get innovative about what all that meant. But are they having any problems filling those spots? Is what I would wonder about
I
at this
think
moment.
it's on the horizon. That's the
Mhm.
scary part, is that um, with the change in the Grad Plus loans and the current political environment, I think
Right,
that
right.
there's significant fear of what is to come. And so there may be now those who are hesitant to apply. So I think we're going to start to see some changes. We don't know what that looks like yet, but I think the next 3 years are going to be a significant, interesting challenge, and it's going to be hard to predict how these changes are going to, I think, unfortunately, negatively affect the development. The hard part is we all know we're losing hospitals. We're not making new ones. And so trying to see how, right? And so hospitals trying to see how to save them. You've got so many of these small district hospitals, maybe have 20 beds. They can't support a residency program alone, but they can in consortium. They can in collaboration. And that's really what I'm hoping to try to get them to change, is that we need primary care. We also need specialists. We're not, and there's certainly the rural areas are missing the specialists, but without primary care, there's nothing. So we have to still do that. I mean, that's been Toro's mission, is to build primary care physicians. We are the #1 medical school producing primary care physicians in the state of California. We are #3, I believe, in creating rural physicians in the state of California. And we are #5, I believe, in creating those who practice in health profession shortage areas. So this is what we do. We live our mission for real. But that means we have to take these smaller hospitals that don't see how they could ever do any type of graduate medical education. We also have to work with ACGME, right? So that's the accrediting body. And in many cases, they say, residents can't travel more than, 50 miles or 35 miles or 40 minutes from one site to another. We also have to work with them to say, we have to be creative, because this is a new world we all live in. It isn't where we have the classic, University
medical
of California,
school,
Los Angeles, right? Giant hospital, medical school,
they're
it's got
across the street
800
from each
beds
other.
and they just take care of all of it. That's not the world we exist in any longer, and haven't for a while. And so if we look at the rural areas, we have to look at it from the standpoint of that collaboration, getting them the right number of patients and education that they need, but also serving the community at the same time. And that does mean those third-year medical students, that core year where they should be in that community, building their roots. Hopefully, many cases, they came from that community, so they go back to train in that community, which even further solidifies their roots. And then they do hopefully their residency there and they stay. And that is how we have people that don't have a mass exodus. Working with, hospitals of all sizes, getting them to understand that the amount of money you waste on recruitment and retention because it doesn't work, invest that instead into medical education in your own facility. That's how we make it work. So we do need some additional medical schools that are specific to those who are in need, like a tribal affiliated medical school, more of those. But we also need more rotation sites and hospitals to be able to support those students.
And I think you and I, in my past job, we did a lot of faculty development, which was reassuring doctors that, we know you're really busy, but if you're not taking time to teach the next generation of physicians in your community, then you're what's going to happen when they need to retire? That particular physician's already going to need somebody that they can retire at a decent age. And also, it's kind of the inspiration factor. I think that's what I took away from your many faculty development lectures that you gave in the northern part of the state, which is that there's actually some real benefits to teaching future medical students or future physicians.
There's no question that we have to remind them that somebody taught you, right? How did you get where you are? We all as physicians wouldn't be where we are if somebody hadn't spent their time and their energy to help educate us. But it isn't their responsibility to do everything. That is the university's job. That's the medical school's job. What the physician provides is an opportunity to see their patients and to work with them. And we know that in a day and age where most people are spending 7.5 minutes with their patient per visit, which is crazy, too short. Medical students and residents afford the patient FaceTime. It improves patient satisfaction because somebody's going to actually listen to them and document everything. Even the MA doesn't have the time because they're running around like a chicken. The nurse doesn't have time, but the medical student and the resident do. And it's
Right.
not about volume, it's about quality over quantity. Yes, they need to see some minimum number, but they don't need to see 30 or 60 patients in a day like a physician might. They might only need to see 4 in a morning. They have an opportunity for those who do need more time to spend more time with them. And the fact is, honestly, it elevates a physician's practice as well because you have someone who's hungry and learning and is up to date on everything that you might not be up to date on. And they can go research something that you don't have time to do while you go see another patient. You're like, well, did something change with how we treat heart failure? Go look that up and bring that to me. And after I see the next patient, we'll see what's going on. It becomes one that it just elevates the entire practice. It lightens everything. And it changes whether the joy that comes back to medicine because we have beaten the joy out of medicine,
Yes, I hear this a lot. Yeah.
right? And I was a residency program director for 12 years for a reason because being around learners changes how you approach your world and it keeps you current and relevant. You can't just sit on your laurels and just say, "Well, what I knew when I went to medical school 30 years ago is still now." It's not. Our
Yeah.
students
Medicine
are
medicine changes and
eh,
medical education changes.
and
Yeah.
now it changes like it's a straight upward curve with AI and machine learning and all these other components. Our students, in many cases, are more savvy than the docs that are out there on some of these things. And so, our job at the medical school is to make sure that they ethically and appropriately integrate the use of technology. And then they can bring that to patient care in a way that their physicians who are attending, who are teaching them, never had the opportunity to do yet. And that's also what we do in graduate medical education is that faculty development to help uplift everybody to the things that are changing within the world so we can do the best possible patient care with the resources we have.
Okay, so we don't have a lot of time left, but I wanted to ask a question. It's again not something that I had told you in advance,
That's
but
okay.
was working with a physician in Northern California and a friend who always said, well, in 20, 50 years, medical schools will not have any walls. So I'm just curious what your vision of a medical school the medical education pathway is so long and so varied that it's hard for me to just say medical school, but that's, I don't know, it's keep it simple and focused on those 3 to 4 years of medical school. What would you see in, let's say, 20 years
So I
for a
think
medical school?
there's a few things, and I think that's where osteopathic medicine comes back and is also unique. Our students get between the medical schools 250 to 400 hours of additional training in the diagnosis and treatment of musculoskeletal disorders and how those integrate with every other system in the body with their hands, which means we
Mm.
still have to touch people, right? We do osteopathic manipulation. We teach them how to do a physical exam that is just amazing and that they understand tissue texture changes and what happens with the body and what that means. I don't see us ever losing that hands on component, and I would never want to lose that hands on component because it is one of the key things that makes us unique and different to the point at which we now have many other residency programs trying to get osteopathic recognition for students who went on to be MDs, medical doctors, instead of osteopathic physicians, who are out there saying, can I learn those techniques? Can I have
Mm.
these additional tools in my toolbox? So, from our standpoint as holistic care, I do see that virtual reality, extended reality will significantly play a huge role in the future. I see AI and machine learning have a significant impact. Opportunities where the students are really integrating and interacting with AI systems to ask them questions, to test them in ways that faculty will still be involved, but probably a little less so. I think a lot of your basic science education is going to be more integrated into AI
Right.
and machine learning.
Mm.
And then it'll be the opportunity for the faculty to be the wise mentor, to finally be the mentors that they know how to be and help people with concepts that they just can't get easily, figure out what that learner needs. Because again, just like our patients are all different, so are our learners. And we have to understand where they come from. Not everybody learns the same way. We know that we have visual, auditory, tactile learners, combinations of all of those. We have some that are synesthetics who feel things and see things differently than the average person. So we have to be able to work with those. And I see that that's still the role of a human being to be able to do that. Where I see there's a lot of telemedicine that will continue. Last time I checked, I still can only do osteopathic manipulation with the patient sitting in front of me to actually treat them. And so I think from our standpoint, that will always be the integral piece of what makes us unique and different. And if anything, we hope that that is more of what the MDs see and embrace. Because even from there, I don't want there to be competition. I want it to be collaboration. I'd like more people to have more tools in their toolbox, more skills to actually integrate and work with their patients. So I do see that it will be a very different world for education. The students are already, watching lectures at quad speed compared to sitting through the methodical lectures and the
Right?
PowerPoints.
Yeah.
Their brains are wired faster. They need shorter bits of information than those of us who sat through 8 hours of lecture every single day. And that's okay because they're developing differently. And so education has to change with them.
Well, thank you so much. If anything that you would say to a middle school student or a high school student who's going, I really want to become a doctor, what would you
I
say?
think it was interesting. I was at the Native Indian Education Alliance. There's also another group that does education really like K through 12 and to college and all of that. And I actually asked a middle schooler, I said, hey, who's Native American, I said, do you want to be a physician? And he looked at me and went, that's something I'll have to think about. And it was very
That.
wise,
Yeah.
but it was also obvious nobody had ever asked him that question before.
Mm-hmm.
So that wasn't something in his community that was ever, nobody asked him of that. So what would I say to anybody who thinks they want to be a physician or a healthcare provider? What advice would I give them? We actually have to help them to have mentors. We have to help them see that this future is a possibility. And for those who've never seen it, it's like, I can only imagine the native populations the first time they saw a ship coming in on the ocean to their land, right? How do you imagine something you've never seen before? You couldn't have imagined. It's pretty hard to do. And we have, certainly there are people who have vision for imagination and future, but I think our job as mentors is to help people see potential futures they've never seen before, to see themselves in ways they've never seen themselves before. So I hope that to that middle schooler or that, second grader would be to say, if you could wave a magic wand, what would you want your world to be like? And what would you want your role to be? And how can I help you do it?
Nice answer. Well, thank you so much. And as always, I enjoy talking with you and catching up.
Same here.
And maybe we'll have you back as a guest in the future. And
That'd be awesome.
I hope to see these future concepts and discussions come to reality in the future. That'd be amazing.
Me too. I feel very blessed to know you. And I feel very blessed to have the opportunity to speak with you today. And hopefully others who will hear what we're trying to say and join the coalition to support our medical care and our medical education for the future. So thank you so much for letting me be here. I appreciate it.
Okay, we'll talk to you soon.
Okay, take care. Bye.
Bye.